Hello, my name is Brooke Smallwood, and I'm the student pharmacist here at the pharmacy today. The patient's chief complaint, she states that she feels bad. History of present illness. She's a 2-year-old African-American female. We have her as a referral from the pediatric oncology clinical physician for febrile neutropenia. The mother states she's had a fever and she's been lethargic all day. Within the past month, she's been diagnosed with acute lymphocytic leukemia. She's also in induction therapy, and this was all within the past month. Past medical history is acute lymphoblastic leukemia. There's no prevalent family history. Social history, it's important to note that the family has chickens at home due to the risk of histoplasmosis with neutropenic and immunocompromised patients. Medications and allergies. The patient has no known drug allergies. Her med list, she takes Bactrim 200 to 400 milligrams per 5 milliliters, and this is 3.3 milliliters BID on Saturday and Sunday for prophylactic PJP treatment. Another medicine, chlorhexidine, 0.12%. This is an oral solution. The directions from this medication are to swish 15 milliliters by mouth 3 times a day for central line prophylaxis because has mucositis to prevent the translocation of the bacteria in the mouth. She also takes Zofran 4 milligram per 5 milliliters oral solution, and this is 2 milliliters by mouth every 8 hours as needed. Dexamethasone, 2 milligrams by mouth twice a day. This is on the treatment plan for induction therapy. Famotidine, 10 milligrams by mouth twice a day. This is protection from GI ulcers due to the dexamethasone. And she also takes vitamin D plus calcium supplement, 1 tablet by mouth daily. She's up to date on all her immunizations. Physical findings, she's positive for fever, indicating neutropenia, redness around the port site, and her vitals and general information. Her blood pressure was 100 over 58 millimeters of mercury. Her heart rate is 118 beats per minute. This is slightly tachycardic for her age. Her Tmax temperature, 39.4 degrees Celsius, which is 102.9 degrees Fahrenheit. Respiratory rate, 25 beats per minute. Her height is 73.7 centimeters. Weight, 10.5 kilograms. Her BMI is 19.3 kilograms per meter squared. BSA is 0.46 meters squared. Just some laboratory and diagnosis tests that we ran. Her CMP is within normal limits. Her CBC is also within normal limits, except her ANC is 90. Her ANC is actually low, so the patient is at a high risk. Her creatinine clearance is 56 milliliters per minute, and we are waiting on the results from the central, peripheral, and the urine cultures currently. Problem stated, the patient has febrile neutropenia. Just some evidence of this is from the 2021 NCC Prevention and Treatment of Cancer-Related Infections. A patient is considered febrile due to temperature of 102.9 degrees Fahrenheit. The patient is considered febrile because hers is over 100.4 degrees Fahrenheit. And her ANC is 90, which is, as we said before, low, and ANC less than 100, and then the onset of illness was in the past 7 days. So this means we need to start therapy immediately. She's also receiving anthracyclines, which this profounds neutropenia. We also indicated that she has redness around the port site. This can indicate she has a high risk of SSTI and catheter site infection per the NCCN guidelines. I would recommend that we add vancomycin to the treatment regimen for prophylaxis. Some goals for the treatment plan. I would like to reduce the fever with Tylenol and initiate antibiotics within 60 minutes so we can eradicate the infection. The first drug that I would like to recommend is cefepime. Mostly because there's a lot of evidence for the use in pediatric patients. The dose would be 50 milligrams per kilogram dose, and the total dose for this patient would be 525 milligrams. This would be IV every 8 hours, and the duration would be 72 hours, or until we have or until the patient does not have a fever. Some safety monitoring for cefepime, renal function, and monitor if the patient has a headache. Most important, we want to monitor the culture results, the count recovery. We want to make sure that the fever does eradicate. We want to make sure that we do not put the patient at a risk for pneumonia with respiratory symptoms. The second drug that I would like to recommend would be vancomycin. The dose for this is 200 milligram total dose, and it is 20 milligrams per kilogram dose. This would be IV every 6 hours, and the duration for this would be until the culture result is negative. For vancomycin, of course, we want to monitor for red man syndrome and any GI side effects, renal function. And then, like we said, for the cefepime, we want to we want to make sure the culture results come back negative, of course, and infusion reactions such as the red man syndrome. The third drug, as I mentioned above, Tylenol APAP for the patient's fever. The total dose would be 160 milligrams, and that is 15 milligrams per kilogram dose. This would be by mouth every 6 hours until the fever subsides. With Tylenol, we want to monitor the liver function because we know it can be toxic to the liver. So we have AOT, AST monitoring, and we want to make sure the patient is afebrile. What questions do you have for me today? Thank you.